Cheryl, you want to take us away?
Yeah, I don't see the introductory slide just yet, but welcome everyone to the ACC SCAI joint webinar on intracoronary physiology and imaging. We've got some great case presentations this morning with a terrific expert panel. Our case presenters this morning will be Ajay Kochar from the Brigham, Akash Garg, and Shabazz Malik. We've, along with myself, we've got Mike Lim from Hackensack University Medical Center as a co-moderator, and a terrific set of panelists, including Dave Cox, Mort Kern, Kiko Mehara, and of course, Poonam Belgapudi, who's going to be, who's been arranging all these webinars. So thanks everyone for joining this morning. This promises to be a great session. Please use either the chat box or the Q&A to ask questions, because we will be fielding questions from the audience as these cases go along, and look forward to a lot of interaction with these cases. So the first case will be presented by Shabazz Malik. So Shabazz, if you can go ahead and share your slides and unmute, we'll get started.
Absolutely. Michael, am I able to share? Like, it's still grayed out over here.
Sure. 1 second, please. Let me know if it's grayed out.
Still is.
Okay, hold on 1 second. Thanks. Sorry about that.
Perfect. Well, good morning, everyone. Thank you for joining us on your Saturday morning. The title of my talk is I Spy with My Eagle Eye, Imaging Guided Coronary Interventions in 2022. I'm an assistant professor in interventional cardiology and structural heart disease at UNMC in Omaha, Nebraska, and the associate program director for the Interventional Cardiology Fellowship Program. I have no financial conflicts of interest to disclose. So once upon a time, there used to be a portly plumber of sorts who was trying to navigate through the forest of illusion. And those of us that grew up in the 90s are very familiar with this Super Mario World video game. And kind of like the Forest of Illusion, which is a labyrinth, the world of intracoronary imaging is pretty vast as well. And the intention today is to try to see if we can maybe decipher some of the nuances to it and come up with a way that, you know, we are able to work through what we're seeing so that we can actually apply it clinically and become better clinicians in the process. So our objectives today is to try to identify the importance of intracoronary imaging for plaque composition, identify the presence and the impact of coronary calcification in plaque once that's been imaged, and then how to deal with calcific coronary artery lesions we encounter during our practice. We'll begin with a clinical vignette. And our story is that of an 82-year-old male who is admitted to our hospital via the emergency department with chest pain. His EKG essentially showed sinus rhythm with no acute ischemic changes. However, his cardiac enzymes were mildly elevated. His peak troponin was 0.29, and this is using the conventional assay with a reference range of normal being less than 0.04. He did recently have an exercise stress echo that showed he had quite a bit of inducible ischemia, primarily in the LAD distribution. All of these segmental wall motion abnormalities are listed here. So 6 segments in total. He had not been set up for an invasive coronary angiogram at that point, though. He was kind of reluctant to be able to go through a procedure and was still kind of mulling it over in his mind. His past medical history, otherwise pertinent for some hypertension. He never had a major cardiovascular surgery or anything else, no significant family history, was a non-smoker, and on some usual home medications, including aspirin, a thiazide, and an ACE inhibitor. He was admitted to our hospital. We started him on ACS medications and then arranged for left heart catheterization. We performed the invasive coronary angiogram from the right radial approach. We used a 6 French sheath. This you see is the right coronary artery engaged with a 5 French JR4 catheter. Not much remarkable there. This is now moving on to the left coronary system. We can see this in a shallow LAO steep cranial projection. We're using a 5 French JL35 diagnostic catheter. And of course, correlating very well with the exercise stress echo abnormality, we can see that there is a high-grade LAD lesion in the middle of the screen. So we initially tried to image this by switching out to a 6 French guiding catheter, an XB35 made by Cordis. We wired the LAD with a Menominal wire made by Asahi, and then the diagonal 1 wire with a run-through NS extra floppy made by Terumo. The IVUS catheter would not pass, and consequently, to be able to make a little more room, we pre-dilated initially with a 1.5 and then a 2.0 semi-compliant balloon, which we see over here, a still frame of. What's also very noticeable is that there's quite a bit of waste and jog boning present, as we initially anticipated. Though we were able to make some room over here, which was encouraging, and then allowing us to be able to pass our IVUS catheter into the LAD to actually image the vessel. This is the intravascular ultrasound, and per convention, we're imaging now from the distal vessel to the proximal vessel, coming up into the mid-LAD, which is where the lesion will be. This is a manual pullback. While we're viewing this, I thought I'd also just kind of mention that there's 2 major flavors of intravascular ultrasound catheters out there. One's the mechanical system, the other's the solid state or phased array. Mechanical essentially means that there's a catheter within a hypotube that rotates 360 degrees, capturing images of the vessel as it's being pulled back. The solid state, though, has 64 piezoelectric elements arranged circumferentially around the tip of the catheter, imaging the vessel as it's being pulled proximally. Both are able to image the vessel kind of in grayscale. The mechanical system goes from 40 to 60 hertz and has nice spatial resolution, whereas the electronic or the solid state has a 20 megahertz system, but does allow for chroma flow and virtual histology as well.
Shabazz, I'm going to stop you there.
Yeah.
Let me just stop you there for 1 second, get some thoughts on this case, because I think this is a great case. It's, it's sort of an unstable angina slash, ACS presentation in an older patient with a very discrete circumscribed lesion, but, clearly you're experiencing some procedural challenges. So let me get Dave Cox in here and ask his opinion. So, when I trained, which is, quite a while ago, if you couldn't get the IVUS catheter to cross, that was sort of a warning sign that there's going to be some real challenges in getting balloons and stents to expand. So Dave, when you hear something about this and you see this, inability to cross with the IVUS without predilation, what are the kinds of things that you're thinking about here in terms of procedural preparation or lesion prep?
Yeah, so it's a great question, and the obvious answer is if the IVUS doesn't cross, then I've got to decide, do I want to predilate an IVUS, or is that enough to say to yourself that you need some lesion preparation technology, either orbital, rotational atherectomy, or now shockwave? And to be honest with you, I'll be interested to see what other people think. I probably would have been pulling my rotablator burr out the minute I saw that 2.0 was so tight. Curious to see what other folks think.
Mort, what are your thoughts on this?
I agree that there's the need to know the degree of calcium is important. I think a small dilatation to let the IVUS do its job is good. I like OCT better these days, but this would do. And then we did our first shockwave a month ago, and I'm impressed, but it's pretty traumatic. So I think a rotablator is not a bad idea, as long as you haven't split the vessel too much. That the old admonition about rotablating after dissection still lingers in the back of my mind. But I think this 85-year-old guy's got some rocks for arteries, and he's going to need a little help with this one.
Yeah, first of all, Shabazz, this is a session on intracoronary imaging, but I want to compliment you on your angiography, because that's where really imaging really starts, and we're seeing an epidemic of shallow angles in our patients who are getting referred to us, and very, very challenging to look at these outside films and see what the lesion is. Oftentimes we have to repeat the angiogram. So let me give you kudos on that. And maybe we can talk during the discussion part about what Mort just said, which is about rotational atherectomy, even though it's not a session specifically on rotational atherectomy after dissection, because I think now in the current era, especially with CTO techniques, people are even rotablating in the subintimal space. But let me turn it back over to you, Shabazz, and tell us what else you did with this case.
Yeah, absolutely. Well, I had some great kind of mentors in the cath lab that really honed in on our skills. So yeah, I think we touched on a lot of different things. The things that were going through our mind were the same, that, if we're having trouble passing the IVUS catheter, what do we do? Do we make some room with a balloon and see if we can image, which is what we have obviously tried. And then after that, okay, what form of plaque modification were we going to go for? So we ended up employing intravascular lithoplasty, coronary shock wave. So we used a 2.512 shockwave balloon over here. They all come in a standard 12 millimeter length, and they go up in increments of 0.5 millimeter from 2.5 to 4.0, delivering about 80 rounds of therapy per catheter. And so we delivered all 80 rounds in that mid-LAD to be able to kind of further plaque modify that area with the high calcium burden that we just saw in the previous IVUS images. We imaged once again after we completed our lithoplasty to see if we had ablated or actually treated the calcium as well as we hoped that we had. And sure enough, when we IVUSed afterwards, these are some of the still frames that I snapped. We can see that, there's certainly change in the plaque over here, and here specifically where I pointed out the arrow, we can see that, we've actually cracked the calcium too. So that was encouraging, because then that allowed us to pass a non-compliant balloon to 275 by 12, further pre-dilate, after which then we went on to getting ready to deploy a stent. We used a 275 by 30 drug-eluting. After we deployed the stent, we imaged once again to make sure that we're able to optimize our PCI, and we decided on post-dilating further with a 3.0 non-compliant balloon. And this ultimately is our final result over here. So we see a well-expanded stent covering that area of disease.
I'm curious, looks like he post-dilated just at 12 atmospheres. In the age of IVUS post-dilatation, do we need to avoid post-dilating to 22 like I do?
Yeah, so it's a great question. And this is a terrific case. I mean, Shabazz, thank you for presenting this, because I love the fact that you imaged several times. So let me address Dave's, I'll give you my opinion on Dave's question, and then maybe we can go around to the panel. And then I'd love to get Dr. Mehara's comments on what we see with intracoronary imaging after lithoplasty. So Dave, I think I certainly grew up in the era of high pressure stent, post-dilation based on some of the ESAR stereo trials. It's interesting, as you look at some of the literature around intracoronary imaging, my impression has been that it's really about stent expansion. And if you can achieve good stent expansion without high pressure post-dilation, that may be sufficient. I'm the editor-in-chief of Circ Interventions. We just published a paper this past month looking at angiographically guided high pressure stent post-dilation versus imaging guided post-dilation. And even with high pressure post-dilation, the event rates were higher than if you used intracoronary imaging guided post-dilation, suggesting that it's really all about the expansion. So let's get some of the other folks in here. So Mike Lim, Alex, Poonam, tell me your opinions on that.
Yes, I'm support double down on that, Sunil. I think the thing probably, Dave, to change over to is not high pressure post stent inflation, but utilizing this technique, as has been shown to us in this case, as an example, what we try to achieve. And it's really the minimal stent area achieved after whatever you do, whether it's just a stent balloon or a post dilation, which I think is the key step here to achieve those longer term outcomes that Sunil just talked about. Akiko, what do you think?
Yeah, I think this case, of course, the stent expansion, not only this case, any kind of case, our goal is good stent expansion, right? But I think in terms of this case, step back, what we see from the beginning. So if I see the 82 years old male, already in my mind, that should be the calcified nodule causing this type of non-STEMI. But when I see the angiographically, the calcium is not too bad. And then I thought maybe this is okay, kind of the calcium. But when I see the calcium by IVUS, you see that some circumferential calcium, it's not too good. And then you correctly using the lithotripsy, making the good calcium fracture. That's we really looking for before stenting to secure the good stent expansion. And then you confirm that's good calcium fracture before stenting. And then finally you put the stent, and then our goal is good stent expansion. And I do think that 12 atmosphere is not good enough. You have to expand much more. This is mid proximal LAD. You should have the much better stent area.
Can I just add 2 cents about the IVL approach? So my compliments again. I think IVL is going to come over rotoblader because it's easier, but we should be aware of a couple of things. That one, I think treating just the stenosis length itself is not enough. You have to treat distal and a little proximal because calcium doesn't always just live at the lesion. So that was one thing. Get a little, those 80 pulses can be shared among several different places, which we did. And the second is, I think that in the year of IVL, which is coming on now, we're going to be required to do a couple of different imaging runs. We'd like to do it before to see the calcium, after we do the IVL to see what's happened, to make sure that it's split, and then after the stent to make sure it's expanded and hopefully opposed, but mostly expanded.
Yeah, those are good points, Mort. Alex, you've been using IVL for a while and doing complex stuff. Is your natural algorithm in the lab similar or to that?
So actually, we don't have IVL yet. So hopefully within the next month. And so I'm a high consumer of rotational atherectomy, but I like orbital too. But I think the key points is what everybody said here. And I think it was interesting what Sunil said about the NCDR data too. The low data reflects, it's not as, we're not using as little intracoronary imaging as it would say, but we're not using it optimally. So as everybody said here, you got to image first, see what you're dealing with, then prep the lesion, treat the lesion, and then image after before you did a good, to make sure you did the appropriate job. And I hear about time, I hear about cost. I think in the US, I'm not entirely sure I'm buying the cost argument. I can understand it other places. And I do not buy the time argument at all, because if you have it set up in your lab and you do it all the time and it's part of your routine, I would submit to you it saves time. And I think that's been the experience of most labs that get in the habit of using it. I've been posting a number of resources in the chat box, for folks too.
Alex, I agree with you. I think people who make the cost argument are using all kinds of things that are way more expensive that are not evidence-based. So why don't we get Shabazz to go ahead and finish up this case and tell us how things turned out.
Yeah. So patient did really well. Like we had him in the hospital for another 24 hours, and he was able to go home on optimal medical therapy. I just wanted to maybe take a few moments to go over why and how we deal with calcium in the cath lab. And so like what we're looking at with intravascular imaging is essentially plaque composition of the 3 layers of the arterial wall. Kind of soft plaque will have this less echogenic kind of an appearance compared to the surrounding adventitia, whereas fibrous plaque is going to be between the soft plaque or the attenuated plaque and the calcified plaque. And calcified plaque is the most echogenic of them all, with accompanying kind of acoustic shadowing that comes along with it. I'm a millennial interventional cardiologist, so I like to try to keep things simple in my mind. And so IVUS being grayscale, I think of fibrofatty plaque being dark gray to light gray, fibrous plaque being light gray to white, and calcified plaque being bright white, but different from fibrous because it has an acoustic shadow that accompanies it. So we can kind of see over here. These are just some examples of various different types. So here, this is a luminal shelf of calcium. This is a calcified nodule. This is a 180-degree arc, and this is a circumferential 360-degree arc of calcium. What we're saying is that if we split the screen up into 4 quadrants, you see calcium in all 4. Why is it important? Because angiography fails to identify calcium in about 46% of cases. And so you might miss out on addressing a calcified lesion. Why is that important? Because if you don't anticipate that, you come into things like listed over here, stent loss, fracture, no reflow dissection. And then exactly like Dr. Mahara pointed out, that an underprepared calcific lesion is going to result in stent under-expansion, which in itself is the #1 cause for in-stent restenosis. And so stent under-expansion is associated with thrombosis, TLR, and MACE. How do we contend with it? I think a fantastic algorithm put forward by SCAI as part of their optimal PCI document that came out just recently, and where some of the things that our illustrious panel already kind of mentioned, where we're thinking if the IVUS catheter isn't passing, what are our options? Either go straight to atherectomy or then try to make a little bit of room with a balloon and then image thereafter. That's kind of the approach that we took. We were able to make a little bit of a channel, got our imaging catheter there, and then assess the plaque for any of the kind of features that would further probably mandate that you should have further plaque modification kind of in your armamentarium ready to go. And so we did identify those things. You had kind of circumferential calcium in certain areas. You had a 270-degree arc for a prolonged length as well. And then we employed lithoplasty over here. Imaged again to make sure that we had, kind of ablated everything well. And once we were satisfied with that, only then did we deploy our stent and then optimized it thereafter. You also want to make sure that I give a shout out to Dr. Mahara and the rest of the group that put together this algorithm too to deal with calcified lesions and specifically over here coming up with an IVUS score. I thought that, this is pretty similar to like the OCT score, but what was great about this though specifically is the fact that now it's also kind of factoring in the diameter of the vessel. So if you have a small vessel, there isn't as much opportunity to be able to expand a stent and get to an MSA of that magic number of 5.5. And so that gives you a point for this, which further would probably push you towards further plaque modification techniques kind of listed over here. And again,
so as we're gonna wrap things up so we can get time for the other cases, I want to thank you for this fantastic case. I think you did this case exactly the way I think it's recommended. You imaged, you treated, and you imaged again to make sure your treatment was sufficient to get stent expansion, and you used intracoronary imaging to guide your stent placement and post dilation. So congratulations, really terrific teaching case, and appreciate you participating in this session.
Absolutely. Thank you so much to everybody, like to the illustrious panel, to my colleague Poonam, Michael, ACC SCAI. It's a great opportunity to be here. Thank you.
Great. We're going to move on now to the next case. And my former colleague, Ajay Kochar, who's now at the Brigham, is going to present a case. And then we'll continue the discussion. So Ajay, why don't you take it away?
Well, thanks so much. And it's great to see you virtually and everyone as well. Let me share my screen here. Can you all see my slides all right?
Yep, we can see, just put it in slideshow mode and we should be good to go.
Absolutely. All right, wonderful. Well, thank you to the ACC SCAI presenting committee for inviting me to present a case that's focused on imaging and physiology. I'd like to thank my colleagues with whom actually we tackled this case together and work very closely together. So Brian Bergmark and Kevin Kroos, and then Rahul Bindi, who's our CHIP fellow this year, and Arnav Kumar, who's one of our first-year fellows who's involved in this case as well. No relevant disclosures. This case is about a 59-year-old gentleman with known coronary artery disease who presented as an outside hospital transfer for consideration of CABG. In his story, he had 2 months of progressive substernal chest discomfort and dyspnea with exertion. He has 2 flights of stairs at home, and every time he got up that first flight of stairs, he really was very uncomfortable. And this really progressed to a point where he just wasn't able to tolerate it anymore. His past medical history was notable for an inferior myocardial infarction in 2018, for which he had 2 drug-eluting stents placed in his proximal mid-RCA that per report were 2.5 millimeters in diameter and post-dilated with a 275 NC balloon. He also had type 2 diabetes as well as hypertension. He had a prominent family history of coronary artery disease, with his father having a CABG at an early age. And to the credit of his local cardiologist, he was on a rather robust cardiovascular medical regimen. He's on aspirin. His DAPT fell off, I think, a year previously. He was on a high-dose statin. He's on a high dose of a beta blocker and a calcium channel blocker, both for his hypertension and as an anti-anginal. And when this started, about 2 months prior to presentation, he was started on IMDUR that was sort of rapidly titrated to 90 milligrams before he came to us. In pertinent studies that were obtained at the referring hospital, he had a transthoracic echo with a low normal EF of 50%, moderate eccentric MR with a hint of hypokinesis in that inferior wall. He did undergo a myocardial perfusion PET there that actually showed transient ischemic dilatation with an EF reduction to 40%, a medium-sized perfusion defect of severe intensity of the entire inferior wall, and the magnitude of reversible ischemia involved about 18% of the myocardium. This led to him getting a diagnostic angiogram. You can see here that the stents that were placed back in 2018 are now occluded. There is a reasonable taper to that proximal cap, but there's that atrial branch coming up. You can see a little hint of contrast that fills a anomalous circ right there. There's some plaque in the mid portion, but nothing significant. Here is an image of the left main and the LAD. There may be some plaque in that proximate LAD. You can see that they're prominent left to right collaterals that really reveal what a large dominant right coronary artery system this was. Our colleagues at the referring hospital actually ended up IFRing the LAD and got a value of 0.85. There was no apparent pullback to see if that IFR abnormality was sort of focal or more a diffuse pattern. So he was transferred to the Brigham for consideration actually of two-vessel CABG in light of his young age, his diabetic status, the transient ischemic dilatation, and the involvement per this IFR of the LAD. But when he got to the Brigham, both our surgical colleagues and we as the interventional team were consulted with the question, what really is the optimal approach to revascularization? I think as with any case, the first question is, do we need to do something invasive? And is medical management reasonable? And in this case, the patient was on 3 anti-anginal medicines, had some high risk features on his stress test, and really had a dramatic reduction in his quality of life. He used to love playing soccer and in fact had to play goalie for the past month. So I think in this case, an invasive approach is very reasonable. Our surgical colleagues thought that he'd be a reasonable low-risk candidate for CABG, but I think we both had a concern about the long-term patency of the lima, despite the IFR value that was appreciated early. From an interventional approach, there's sort of several different potential approaches that we could take. One would be to do an LAD PCI, followed by a staged RCA CTO intervention if there were residual symptoms. We could be particularly aggressive and do an RCA CTO and an LAD PCI, or we could tackle that RCA CTO followed by a repeat LAD IFR to assess what the true physiologic significance of that donor vessel is afterwards. And that's really the approach that we took to this case.
So Audrey, let me just stop you right there, because I think
Sure.
these are great management questions. This is terrific. It's a great case. We see this kind of thing all the time. So, one of the big issues here is, how do you interpret the physiology of a donor vessel when there's a CTO? And this comes up all the time and these decisions have major consequences, because you're trying to often decide between bypass surgery or multivessel PCI, and that is not a trivial decision, both for us or the patient. So let me ask Dr. Kern. So if you've got moderate LAD disease and you've got a right coronary CTO that is supplied by collaterals, how do you interpret the FFR, IFR, any other resting index, or can you not really interpret it? And should you really do what Ajay is suggesting here, revascularize the CTO and then reassess?
Okay, great question. So the FFR has been demonstrated in patients who have a supply to an occluded bed, LAD supplying an occluded right coronary, FFR is, let's say it's 79, and then you revascularize, you reduce the dependent bed through the LED, the right is now revascularized, blood flow to the inferior wall is not needed, and the FFR goes up. So it goes from 79 to 82, 84, whatever. It has not been demonstrated for resting flow for the IFR that this is the same phenomenon. And in a third of the cases that have such an arrangement of collateral bed supply, it may or may not change the FFR and the LED. So there's a couple of factors. One, we're not sure that the FFR and the LED will change by supply. My guess is in such a very vigorously opacified distal bed collateral, grade 3 collaterals to the right, there probably would be reduction of flow across the LED and the FFR would go up and you probably wouldn't need it. I can't say that for IFR. Theoretically, the resting flow shouldn't change very much, no matter what the bed is. And, you know, it's auto-regulated to one level. And if it's adequate, it's adequate. So it'd be a good test. I like your approach, RCA CTO followed by reassessment. That's a secure. I was puzzled that the surgeons would decline an LED that was positive with a total right and make some argument that it might not stay open. I think that's a cardiologist argument, not a surgeon's argument. But nonetheless, I hope that's, I mean, in a nutshell, you want to see how the physiology of the supply bed will change the physiology of the target lesion, of a target lesion.
So to just stay what you just said, Mort, but to maybe add some practicality to it, if you're the interventionalist taking this person to the lab for this approach as outlined on the bottom, the opening of the CTO of the right coronary artery is fine. Repeating the LAD with physiology then gives you the appreciation for what the LAD looks like in its own. And I think the unstated thing that has to be stated here is the operator and the patient have to be ready, willing, and able to intervene on that LAD if that physiologic measurement didn't change as anticipated. Meaning, don't assume something's going to happen so that you're just going to measure that IFR at the end and it's going to be fine. You have to be capable and prepared to deal with it.
Always.
Yeah, really quickly, maybe I'll ask the panel this question. You know, I think the situation that you and Mort are talking about is when the LAD FFR is abnormal in the presence of a right coronary CTO, because you know oftentimes those patients will be referred to bypass. We have a little bit of a different situation here. The LAD FFR is actually normal. It's you know 0.85.
This is an
In that
IFR.
situation, do we? I mean, can you take that to the bank and say the LAD is not ischemic, and
Well,
no need to repeat that?
Yeah, so this was not an FFR. This was an IFR, if I recall correctly.
Yeah.
And
Yeah.
so an IFR of 0.85 is considered fairly
positive.
strong abnormal. I think if you did an FFR, it's likely to be abnormal as well. Probably not far from the border, but certainly my guess would be abnormal. Remember, a contrast FFR threshold is 0.83. Doesn't take much to get your PDPA down below 83 with a squirt of contrast. So I think this is a positive LAD through IFR, likely contrast, certainly FFRs in that range.
Mort, help me make sure I don't misunderstand FAME3. So what does FAME3 tell us about this particular case?
FAME3 said that if you have complex multivessel disease, the FFR doesn't add to your outcome events, multiple significant lesions. This one would probably be a syntax intermediate 20, 25, maybe less, and you can go either way. And certainly if the syntax score is low, then benefit was given to the FFR PCI like in the FAME1 and FAME2 studies. So FAME3 favored surgery for complex disease. And it did identify some patients who could get away with fewer stents when they went in that direction.
Yeah, you're right. I missed that. This is the IFR, not FFR. But maybe we'll just, as a thought experiment, let's say the FFR or IFR was normal in that LAD. Then can you just basically say, okay, this is one vessel disease. We could just work on the CTO.
I think you can.
Okay. Good. Sorry, Ajay, why don't you go ahead?
Yeah, sure. I mean, I think as with all things, you know, the patient comes at the center, and so part of this was sort of a multidisciplinary decision with the patient at the center, and I think he felt pretty strongly about at least trying a percutaneous approach first. His father had gotten a CABG, and so had sort of learned from that as well. And we felt that that option would certainly be on the table if needed as well. So proceeding with the actual case, our interventional approach using sort of standard CTO techniques was to use dual access for visualization. We went right radial with a 7 French EBU 3.5 guide to help visualize the distal vessel, as well as anticipating the potential need to go retrograde if needed. And we thought that the septal collaterals were actually quite favorable interventional collaterals. And then we went right common femoral artery with an 8 French system using an AR2 guide with an 8 French trap liner. The CTO was an in-stent CTO, and so we thought an antegrade wire escalation approach would be very reasonable, taking a pilot 50 backloaded on a turnpike LP with the plan to escalate rapidly to a pilot 200 or a Mongo wire. And as I alluded to earlier, sort of using a retrograde approach if needed. So here's the initial image. You can see there's a BMW wire in that septal as a placeholder from the left. We've got the turnpike LP sort of distally in that stent. And that, I believe, is our pilot 200. You can see we are not in the vessel architecture. We spent some time trying to get in the true lumen, but we're unsuccessful from an antegrade wire escalation standpoint. So we ultimately shifted our approach to a retrograde approach. That's a Xi'an black that you can see we've navigated through that septal collateral into the RPDA with the microcatheter being a Mamba Flex. We got that Mamba Flex up close to the distal cap, tried to penetrate the distal cap with a pilot 200 and a Mongo. Were unable to do so. And so then again, shifted approach to a reverse cart approach. We knuckled a Mongo antegrade, initially used a 1.0 sapphire balloon and then upsized to a 3.0 sapphire balloon. And after doing so, we're able then to navigate pilot 50 into that 8 French trap liner that you can see here. Spun the Mamba up and exchanged that pilot 50 for an R350 externalization wire. Through that, we got an IVUS down for 2 key reasons. First was to really understand what the mechanism of that in-stent restenosis and occlusion was. And second, to give us a sense of what the distal vessel looked like, what the extent of disease was, and the severity of the distal disease was. And here's some still frames of the IVUS imaging. You can see the proximal RCA ISR. There really isn't a ton of calcium, but the primary mechanism probably for this in-stent restenosis and occlusion was under expansion. As I alluded to earlier, the stent was around a 2.5 stent, but the true vessel size was around 4.0. And you can see distally there in the RCA that there's a fair atherosclerotic burden that exists there as well. And so, you know, our sort of internal approach to these ISR cases is to use a 1-to-1 NC balloon. Oftentimes, if there's a lot of neointimal tissue, to use a cutting balloon, whether an angiosculpt or a Wolverine. And if there's a lot of tissue, and particularly if there's a lot of calcium, to laser if needed, and then to sort of upgrade from there. But as you can see here, this is a 4.0 NC balloon that's expanded quite well. Over the years, I've gotten disciplined about trying to check that in orthogonal views, especially with nodules. I've appreciated that sometimes, you know, in one view, it looks like expansion is great, but in an orthogonal view, it's less than optimal. And so we felt like we had good expansion of the stent here, and we ultimately deployed a 4.0 28 synergy proximally, a 3.0 38 in the mid vessel, and then we did have to cross the bifurcation distally and put a 2.5 38 into the RPDA. And I'll show you an image of the vessel. You can see it's a really massive right PDA or right coronary artery system with a large right PDA. And at this point, we did do an IFR of the LAD. Following that, you can see that the IFR here was 0.9, 0.91. And so we elected to sort of just pause here and not go further in terms of intervening at the LAD. I apologize, didn't include the pullback, but it was sort of a diffuse and not really a focal abnormality that we sort of expected based on the angiography of the LAD. And so as sort of,
Roger.
Yep.
No, go ahead. I'm sorry. Go ahead.
Oh, sorry, no problem. So as sort of key conclusions, and this is sort of directed to the fellows, don't hesitate to ask for help. I had the immense privilege of training under Sunil and some phenomenal faculty at Duke, but I hadn't scrubbed on a ton of retrograde cases, and so leveraged the resources that we had. So certainly if as you're looking to start on faculty or in practice, make sure to lean on your colleagues for help. Invasive physiology measurements can reflect the degree of myocardium subtended, including collateral flow, especially for FFR. Ischemia in a donor vessel is not uncommon and may normalize with successful CTO recanalization. And intracoronary imaging can help minimize the risk of underexpansion, as was alluded very elegantly in the prior case, which is a major risk factor for in-stent restenosis. And as a corollary to that, if you are treating in-stent restenosis, intracoronary imaging really helps to identify what the mechanism for that is and help guide management. And with that, I'd like to thank everyone for joining and for the panel for a wonderful discussion.
Roger, that was awesome. And I think that your case gives what would be my answer to Dave Cox about FAME 3, and that is that these tools like FFR or coronary physiology and IFR in your case, as well as IVUS, help us provide interventions to be the best that they could be. But they're not a be-all, end-all for us to necessarily displace cardiac surgery or bypass grafting. And so I applaud the concept of conjoining very good use of the modern day CTO technique, as well as the understanding of coronary physiology, but the ability to continue to use these techniques to get your best outcome for the patient, because that's after all what we're after. And we want this patient that you just treated to continue his expertise and his prowess on the soccer field and everything else for years to come. So congratulations on that.
Yeah, terrific case, and I think you saved this patient really from having to have bypass surgery. So we're going to move on now to the last case, and that's going to be Akash Garg, who's going to present a case that's going to be very interesting. I think it will spark a lot of discussion. So Akash, why don't you take it away?
Looks good, Akash. We can see it.
Looks good. Thank you.
So thanks for giving me the opportunity. So following the two great presentations, this morning, I'm going to present a case on case of stent restenosis, and hopefully we can, as I go through the case, we can talk about the role of imaging. So so this gentleman is an 81-year-old male. He presented to us about 4 months ago with unstable angina. His past medical history is significant for hypertension, typical risk factors, hyperlipidemia, he is diabetic, he has CAD, he has had PCI to his LAD in the past, peripheral arterial disease, and AFib. His physical exam was really unremarkable except a grade 2 systolic murmur, and his EKG showed a ventricular pace rhythm. So going to the diagnostic angiogram on the left panel, this is the selective RC angiogram via right radial approach, and really not much disease, diffuse distal disease, but non-obstructive. And on the right panel, we'll see, this sort of, it's an arteriocaudal projection. You'll appreciate a mid-LAD sort of severely calcified lesion, and this is a cranial projection. Again, it's angiographically, 95% stenosis, severely calcified lesion. So at that time, as opposed to the first presentation by Shahbaz, there was no pre-PCI imaging done, but the decision was made, given the angiographic appearance of severe calcification, the decision was made to do rotational atherectomy using a Rota 15 burr, followed by non-compliant 3x20 balloon for lesion prep, and then followed by the Onyx 3x38 stent implantation. So, this is the post PCI angiogram on the left panel, which shows, I think decent result, good expansion angiographically, and not much residual stenosis. And on the right panel, I'll play the OCT image, which again shows, I apologize, I don't have the measurements. We don't have co-registration in our lab yet, but overall, good stent expansion. And I'll pause this for a second where I, give me 1 second. And I think maybe some protruding thrombus here. Integralin was given interprocedurally as well. But overall, good stent expansion and, apposition. So the patient was discharged. He did well. He was seen in follow-up visit and then managed at this point with Coumadin and Plavix. However, unfortunately, 3 months later, he presented to the ER with recurrent chest pain, and he was ruled in for an NSTEMI. So at this time, he had an urgent angiogram, again via radial approach. This is RAO caudal projection, and you can see there's a focal area of significant stenosis within the recently stented segment, right? And this is again a cranial projection, again illustrating the same finding. So at this point, I wanted to just pause and see if moderators and panelists, have any comments so far.
Yeah, thanks, Akash. Really sort of a challenging case here. So let me just start with, maybe Dave Cox here. And what are your thoughts on this? This is a patient who had a repeat PCI. This time imaging was used post PCI, looks pretty nicely expanded. And he comes back 3 months later. What's going through your mind?
Yeah, I'm totally intrigued, Sunil. First of all, it looked like by IVUS it was fully expanded. I think a 3.0 and a proximal LAD is always cause for pause. So you wonder if maybe I could have gone bigger, but I'm intrigued that it's a very focal narrowing. I mean, it's that classic issue. It's as opposed to a GR2 where we had RS from dot to dot. I'm intrigued by this, and I definitely think we got to do some imaging here to try and understand what's going on. It doesn't look like it's a particularly bendy artery right there, but you sort of get wonder about the integrity of the stent.
Yeah, Akash, if you could go back to your slide where you had the OCT, I'll just ask Dr. Mehara. I don't know if it's a still image of the OCT, so maybe a little bit challenging. But Dr. Mehara, what are your opinions on the OCT here? This is post PCI, I guess, just before the final pictures. Are you able to go back?
Yeah,
Yep, and I can pause it right here.
I remember how it looks like the OCT picture. This is very, very severe calcium. It's very thick and circumferential. And we see the very nice polished surface by rotablator, which is very typical. At the site of the polishment, I see the nice calcium fracture, like not just one, like multiple. So this, and then stretching the non-calcium site a lot. That's how it looks like the expansion of the very severe calcified plaque. And it was really well done, but which I don't see any is actually calcified nodule. Because this is a very severe calcium, we should expect the calcified nodule to be there. But at least once the picture I didn't see. But this type of the very relatively early, like focal stenosis, under the very severe calcified lesion, one thing in my mind, this could be reprotruding the calcified nodule. But at least I didn't see the calcified nodule on the picture at the time of the index procedure.
And Akash, just remind us, this is the second layer of stent this patient has, or just the first layer?
It's the first layer.
First layer. Okay, so this is okay, got it. This is a restenosis of the first.
Still a stent, but we did a slight overlap, but this was the first layer of stent to his mid.
Okay. We lost your sharing. So if you go back and share again, we'll let you continue with the case.
While you're doing that, I guess I'll emphasize that this is a critical spot in which I agree with David Cox that imaging is 100% essential. And I think we're seeing this all too frequently where operators are willing to put in a second layer of stent for this focal problem, which is not going to end up with ultimate good results moving forward. And moving my new institution, now I've seen multiple cases in which we have 2 or 3 layers of stent to treat a similar type problem. As all of you know, the second and the third layer of the stent makes it just exponentially harder to deal with rather than easier. So now is the time to actually really address the fundamental underlying problem and not just put in a stent as a Band-Aid approach.
I think that's a great comment, Mike. And Alex, let me ask you your opinion. How many tries do you give somebody with PCI? I mean, let's say you get some. You have a big referral population, I'm sure, and probably get patients who've got
Alex
to.
signed off, Sunil. He had
Yeah.
Oh,
to
you
take
did?
his
Okay,
kid to
well,
a swim meet. So
Yep.
okay, well, that's more important for sure.
Family comes first.
Yeah, absolutely. Well, let's ask the panelists. And Mort, I mean, how many tries do you give somebody? You got someone referred to you with a couple layers of stent. Do you give them one more try, or do you say, okay, this is not working. Let's consider bypass here.
Well, I think after you've got 2 layers in there, the third layer often doesn't work. I think 2 times is as much as I would do. Now, the options after that are brachytherapy or surgery. And I guess you could do some other stuff, but the guy's obviously a stenoser. And despite maximal best anatomic approach, you're not going to win that. So I'd say 2.
Well, let me ask you that, Sunil. My best guess is that this patient has a focally fractured stent, which led to this focal restenosis. And so would you provide that second layer of stent here and believe that that's good enough moving forward, or would you stop now?
Yeah, so that's a great question. And we have this debate quite a bit, I think, among ourselves, which is, someone comes back with a couple layers of stent. And, I think, is this an inherent biological issue to the patient? Or is it the fact that there's just a lot of poor quality angioplasty being done? And I suspect that it's a little bit more of the latter. Because, when we image these cases and, you look, you see a lot of what Audrey showed in his case, 2.5 millimeter stents and 3.5 millimeter vessels. And those, if they've been in there for a while, can be very, very challenging to expand. Now, if this is in the right coronary, for example, you certainly don't want to send a patient for sternotomy in a right coronary. So our limit has been 3 layers. I don't know if that's the right number or the wrong number. And, we use everything that we can in our armamentarium, whether that's IVL, Rhoda, a combination of the 2, laser bomb, to try and do our best to expand those. We have sent a couple of cases to get intracoronary brachytherapy. There are only a couple of sites in the country that are doing it right now. We have published in Circuit Intervention some outcomes for intracoronary brachytherapy for DES restenosis, and the outcomes are summarily very, very poor. And so what I think we have to get to as a community is really optimized PCI to prevent this kind of thing from happening. And I think in general, most patients do great, which is why I think we tend to get a little bit cavalier about PCI. But hopefully, if we can increase the uptake of intracoronary imaging, some of these decisions will become less common.
Great points, Sunil. I think you got to get it right to begin with. Brachytherapy, sadly, is not the answer. How about drug-coated balloons when you have 3 layers of stent? Do you think that'll go? Do our European colleagues have any data?
So great question. I'm not as familiar with the DEB data. What I have seen about drug-coated balloons is that they seem to be reasonable, although they've been studied largely in sort of simple lesions. And I think some of the trials that are ongoing right now are IDE trials looking at restenosis, and they're testing plain balloon versus DCB. And I'm not sure the plain balloon is what most of us are doing now. So I think it's going to be challenging to interpret those data. Looks like we have Akash back. So Akash, why don't you go ahead and tell us what happened here?
Log back in. Thanks for the patience there. So, we don't have stent boost technology in our ED lab, but on a closer cine before the contrast, you do see some suggestion that whether this is a stent distortion. So, but as the panelists or moderators, you guys said that suggested imaging. So we did do OCT, and I'm gonna again pause here for a second, where the significant restenosis is.
There is definitely there is no strut at all somewhere.
Exactly.
So
So, you know,
this is chunk of the neointima, but you move a little bit. Oh, yeah.
right, so I'm gonna share the next screen. So again, here, so these are still images. So, you know, a lot of restenosis, neointima, but here you don't see any struts at all. And on a 3D reconstruction on this panel, you know, absolutely see the stent struts missing here. Complete.
Would
No,
we have seen this on IVUS if we don't have OCT in our lab?
It's a pretty large separation. I would think you'd see it on IVUS. We're not doing it we're doing almost zero 20 megahertz IVUS anymore. It's all HD in our shop, but clearly the OCT shows it very, very nicely. It's an interesting case. You know, when we did the across cipher trial of cipher stent and CTOs, most of these stent fractures occurred in the right coronary just because of the motion of the right coronary. And the incidence was as high as 11 to 12%. I mean, that was a very, very stiff stent. Akash, what do you think is the mechanism of the stent fracture here? Is it just torsion on the vessel is there a hinge point that we're missing?
That's a great point. And I think, you know, it was a combination of hinge point, as I'll show you in another picture, and severe calcification. But let me go
but
actually.
before moving that picture, go back to your picture. We should
Sure.
not misunderstand that picture. So 3D reconstruction on the right-hand side, this is not everything showing the stent fracture, because this 3D reconstruction is using the stent strut, making that white stent structure. So if you have the chunk of the neointima on the top of the stent, the 3D structure is like this. So don't think this is all fracture. But when you see the circumferential picture, as you shown correctly, like 6 o'clock, like 5 o'clock, there is no strut at all. So that's real. So we have to consider, based on the cross-sectional picture, this is stent fracture. That's correct answer, but not just based on the right-hand side 3D picture. Sorry, go ahead.
And
No, that's really important information. Thank you for that.
To answer or add to something that Dave Cox just alluded to, I wonder whether the automatic pullback imaging of this type of a thing is far more accurate than manual pullback through this type of a thing. So, you know, obviously the OCT it mandates that, but when the operator sort of quickly whizzes in and out with an IVUS catheter, you don't necessarily get the definition across all of the area. So I would encourage everybody to use the actual automatic pullback functions here to see this type of a defect.
Okay, go ahead, Akash.
So, you know, so at this point, we decided, you know, that we were pretty convinced this was a stent fracture. So we decided to put a new stent in, and this was we decided for a Zynes versus Onyx this time, just because we had stent fracture with the Onyx stent. So we used a 3/18 stent and post-DIL with a non-compliant 3 to 5 by 20 high pressure balloon. And, you know, this on the left panel, this is the post DES picture, you know, which is pretty decent result. And this is the final OCT. And I'm happy to pause this at any point if any of the panelists have comments.
I'll tell you what, we just have a few minutes left. So why don't you go ahead and wrap up, and then we'll have some final comments.
So, you know, I did want to mention this brief slide about instant restenosis classification, which was recently proposed by Dr. Waxman. You know, and it nicely illustrates both the different patterns of restenosis as well as, you know, as a guidance to therapy. So type 1 is essentially a mechanical problem, whether it's stent underexpansion or stent fracture. Type 2 is a pathological problem, which could be neointimal hyperplasia, calcified or non-calcified neoatherosclerosis. Type 3 is a mixed pattern, and 4 is a CTO, and 5 is if there's, you know, more than 2 layers of stents. And I think this is a very nice classification, obviously, because each you know type has sort of different treatment options and you know management options. But for stent fracture, obviously, you know, DES is the only way. And this is what is known as Dr. Popma's classification of stent fracture. You know, just I think more for research purposes. But type 1 is, you know, single strut fracture. Type 2 is incomplete transverse with a V gap. Type 3 is complete transverse, but no displacement. Type 4 is a type 4 stent fracture is complete transverse with displacement. And the reason I decided to mention that, because in more recent research studies of stent fracture, large-scale studies from mostly Asia, and this is the classification they used. So just to wrap it up, intravascular imaging helps identify mechanism of in-stent restenosis. The incidence of stent fracture is, has been variable depending on modality, but the most recent imaging studies have shown about a 12% incidence. And, predictors are lesions with hinge motion, calcification, and tortuosity. And it's associated with very high rates of in-stent restenosis, as high as 50% within the first year or so. High rates of stent thrombosis and TLR. Thank you.
Nice.
Great, that's terrific, Akash. I want to thank everyone for attending, and I'm going to just go around the panel and just ask for final thoughts on this. I mean, honestly, we could be talking about this all day long. Really great cases, so thank you to all the presenters. So my co-moderator, Mike Lim, final take-home thoughts?
Yeah, so awesome 3 cases and great presentations demonstrating the value of imaging and physiology in today's cath lab. I think these tools are designed to optimize our outcomes in the cath lab and optimize patient outcomes. And I thank everyone for participating.
Dr. Mehara, final thoughts from you?
2 things. 1, we have to do best job during the index procedure with physiology and imaging guidance. 2nd, even you do your best, if failed, you have to see what's the reason by intravascular imaging first.
Fantastic. And Dave Cox?
Do it right first. Don't be afraid to text, call, email your colleagues, friends to ask questions. And it's a joy to participate in this. There are all 3 great cases.
And Dr. Kern?
Illustrated the real value of these tools. I think if you're not using physiology and imaging in your interventional practice, you shouldn't be practicing intervention.
Fantastic. And I'm going to ask Dr. Velagapudi for the last word here and to set up the next webinar. So Dr. Velagapudi?
I think our imaging use is not yet up to mark. I think I would encourage all, trainees and early careers and as well as everybody to increase imaging. No rota regret, no imaging regret. That's what I want to say. And final comments also from you, Dr. Rao.
Well, I want to thank all the presenters and everyone for joining us on this Saturday morning. These are terrific cases. I want to echo what all my panelists said, and I also want to encourage those of you who are post-fellowship. If you don't know enough about physiology and imaging, please check your ego and learn about it. I did that. I went to a fellows course about 5 years ago, even though I was well past fellowship, because I just didn't understand how to interpret imaging. And I tell you, it's made a huge difference in my practice. So thanks, everyone, for joining. Stay safe and healthy, and we'll see you on February 19th for the next one.
Thank you.
Thank you, everybody.